Welcome to the deep dive. This is where we take really dense source material, like a whole chapter from Kaplan and Sadock's Psychiatry textbook, and pull out the key stuff you need
Yeah,
fast.
yeah, making it manageable.
Exactly. Today, we're plunging into the world of impulse control disorders, or ICDs.
Right. And our mission today for you is really about clarity and efficiency. We're going to break down the diagnostic criteria, the theories behind them, and the treatment options for three specific conditions: intermittent explosive disorder, pyromania, and kleptomania.
Right.
We'll sort of walk you through the key details, almost like picturing the tables and descriptions from the book, but in plain language.
And the thread connecting all of these is really interesting, isn't it?
Hmm.
It's this fundamental failure to resist an urge,
Uh-huh.
this buildup of pressure inside, and the only release comes from acting out, often in a harmful way. That internal struggle is what we're focusing on.
Precisely. It's that impulse winning out.
So let's start with the big one. Intermittent explosive disorder, IED. The sources say it affects quite a few people, maybe 5% to 8% in the U.S. over a lifetime.
Yeah, that's a significant number. And what's really critical for understanding IED is the nature of the aggression. It's reactive, it's impulsive, meaning the outbursts happen fast, they're not planned out, usually last less than half an hour, and are often set off by someone they know or some kind of stressor.
Okay.
But the absolute key point, the aggressive reaction has to be way, way out of proportion to whatever triggered it. Grossly disproportionate.
So that's the real dividing line, the motive, right? It's not like antisocial personality disorder where aggression might be used to get something.
Exactly. That's crucial. IED aggression is about anger and impulse, pure reactivity. It can't be done to get money or power or to intimidate someone in a calculated way. That rules it out.
Makes sense.
So when clinicians are looking at the DSM-5-TR criteria, they need to pay close attention to criterion A. It actually lays out two different patterns, frequency-wise.
Okay, can you walk us through those? Because the timing and severity seem really important for the diagnosis.
Definitely. So pattern number 1 is about lower severity aggression. Think verbal stuff, arguments, shouting, or physical aggression that doesn't actually cause damage or injury, like pushing, maybe?
Right.
That pattern needs to happen on average twice a week for about 3 months.
Okay, twice a week for 3 months. And the second pattern?
The second one involves high severity aggression. This means outbursts within a year specifically, 3 of them in a 12-month period that involve damaging property or actually assaulting someone, causing injury, or injuring an animal.
3 times in a year for the serious stuff.
Got it. You only need to meet one of those 2 patterns, not both.
That helps clarify things.
Yeah.
But you mentioned earlier, IED often comes with other issues. How tough is it to separate IED from, say, other disorders where aggression is a feature?
That's the challenge. You have to carefully rule out other potential causes, borderline personality disorder, maybe the effects of being intoxicated, or even aggression linked to major depression. And probably the single most important detail for differential diagnosis is the age limit. The person has to be at least 6 years old.
Why 6?
It helps make sure we're not just pathologizing normal temper tantrums that little kids have. You need that developmental context.
Right, okay. And it rarely exists in isolation, you said.
Almost never. The comorbidity is incredibly high. Our sources point to about 81% of people with IED also meeting criteria for at least one other disorder.
Wow, 81%.
Yeah. And interestingly, the IED often shows up before things like substance use disorders or major depression develop.
Which sort of leads naturally into asking why this happens in the brain, the etiology. You sometimes hear about that old case, Phineas Gage.
Ah, yes, the classic neurohistory case. Gage's personality changed dramatically after that railroad accident damaged his prefrontal cortex. It was really one of the first stark illustrations of how crucial that brain region is for controlling impulses and behavior.
So that case pointed to the hardware. What does modern brain imaging tell us now about IED specifically?
Well, modern research really doubles down on that frontal lobe connection. Studies consistently link dysfunction there, especially in areas like the orbitofrontal cortex and the dorsolateral prefrontal cortex, to increased aggression.
So the brain's braking system isn't working right.
Essentially, yeah. But perhaps the largest body of evidence isn't just about structure, it's about brain chemistry. Specifically, the neurotransmitter serotonin, or 5-HT.
Serotonin. That usually makes you think about mood, right? Depression, anxiety.
Exactly. And there's a huge amount of evidence linking reduced serotonin function to increased impulsive aggression. We see lower levels of serotonin's breakdown product, 5-HIAA, in people with aggression issues.
Okay.
And you can even show it experimentally. If you temporarily lower serotonin levels in people by depleting tryptophan, which is its building block, you see aggression levels go up.
So if the root problem involves poor frontal lobe control, potentially mediated by low serotonin function, how do we treat it effectively? The goal isn't just to calm people down short term, right? It's long-term reduction without sedation.
That's the aim. And pharmacologically, given that strong serotonin link, SSRIs are often a first-line approach. Controlled studies do back up their effectiveness in reducing impulsive aggression.
The sources also mention mood stabilizers, like lithium. That's interesting because of its anti-suicide effects too, but isn't lithium tricky to use?
It is. Lithium has what we call a narrow therapeutic window. That means the dose needed to be effective is quite close to a dose that could be toxic, so it requires very careful blood level monitoring.
Okay.
For some patients, anticonvulsant medications might offer a better risk-benefit balance. Drugs like valproic acid or Develprox and topiramate have shown good results in placebo-controlled trials for reducing impulsive aggression, especially in people who score high on measures of impulsivity.
What about non-medication approaches? Therapy?
Oh, absolutely. Cognitive behavioral therapy, CBT, has solid evidence behind it. There was a key randomized controlled trial showing that 12 sessions of CBT, either one-on-one or in a group, significantly cut down on aggression, anger, hostile thoughts, and even depressive symptoms in IED patients.
And did the effects last?
Yes, the improvements were maintained during the follow-up period, which is really encouraging.
Okay, so we've got this picture for IED. Intense internal pressure, impulsive release. Does that same kind of irresistible building tension followed by relief apply when we shift to our next disorder, pyromania?
It absolutely does. That tension relief cycle is the core feature of pyromania. The diagnosis requires deliberate, purposeful fire setting on more than one occasion, and it's driven by this feeling of tension or arousal building before the act, followed by intense pleasure, gratification, or relief during or after setting the fire.
And the sources mentioned this fascination they often have, not just with fire itself, but with fire departments, fire equipment.
Right, that fascination is a key part of the picture, and it helps highlight the crucial difference between pyromania, the psychiatric diagnosis, and arson, the legal term.
How so?
Pyromania is all about that internal emotional state, the compulsion, the tension, the relief. Arson is fire setting for external reasons. Getting insurance money, revenge, hiding another crime, making a political point. If any of those motives are present, it's not pyromania, even if the person enjoys fire.
It sounds like true pyromania must be incredibly rare then. Is there much data on it?
It's considered very rare, and good epidemiological data is lacking. We know general fire setting is more common, maybe about 1% lifetime prevalence in some samples, but a study looking at people repeatedly convicted of arson found only about 3.3% actually met the criteria for pyromania.
Why so low?
Often, the arsonists in that study were intoxicated when they set the fires, which is actually an exclusion criterion for a pyromania diagnosis. The act has to be driven by that specific tension relief cycle, not clouded by substance effects.
Interesting. Now, historically, Freud had some ideas about pyromania, something about psychosexual development.
Yes, that was his interpretation, linking it to urethral eroticism, but that view isn't really held today. The modern perspective, though still not well understood, tends to circle back towards potential brain mechanisms.
Like the frontal lobe issues we saw in IED.
Potentially, yes. There's mention of frontal inhibitory dysfunction. One case report used SPECT imaging, a type of brain scan showing blood flow, and found reduced activity, a perfusion deficit in the left inferior frontal lobe of a person with pyromania.
And did that change with treatment?
Yes, intriguingly, that deficit reportedly resolved after the patient got treatment, which involved CBT and the medication topyromate. There are also newer hints from case studies about possible genetic links involving dopamine pathways.
So treatment is still largely based on these individual cases rather than big studies.
Exactly. That's the major limitation. There are currently no FDA-approved medications specifically for pyromania. We have these scattered case reports suggesting potential benefit from SSRIs, lithium, naltrexone, even topiramate.
But psychotherapy sounds promising, especially for kids.
Yes, particularly CBT. There was one important study comparing different approaches for children with fire-setting behavior. It found that CBT was significantly better at reducing both the fire setting itself and the interest in fire compared to just giving them fire safety lessons or having a firefighter visit their home.
Okay, that makes sense. Let's move to our third disorder, kleptomania. This one seems, maybe on the surface, the clearest example of that core ICD pathology, the pointlessness of the act itself.
Absolutely. Kleptomania is defined by the recurrent failure to resist urges to steal things. But crucially, these are objects the person doesn't need for personal use and doesn't need for their monetary value. They're not stealing to sell things or because they're poor.
It's purely about the act of stealing.
It's about the urge and the relief. The emotional cycle is identical. That rising tension right before the theft, followed by pleasure, gratification, or relief at the time of the theft. It's very similar in a way to the cycle in OCD.
And unlike maybe the momentary satisfaction someone with IED might feel, the sources say the urge in kleptomania is often ego-dystonic. What does that mean?
It means the person experiences the urge as unwanted, intrusive, and distressing. They don't want to feel this urge to steal. This often leads to intense feelings of guilt and shame after the act, contributing to depression and, unfortunately, a higher risk of suicide.
How common is it?
In the general population, it's estimated between 0.3% and 0.6%. Pretty low. But if you look at psychiatric inpatient settings, the rate jumps dramatically, maybe up to almost 8% current prevalence.
Wow.
It's also notably more common in women. About 2/3 of cases are female. And the comorbidity rates are sky high, especially with eating disorders and perhaps most significantly, obsessive-compulsive disorder.
OCD again. What's the overlap there?
It's huge. Depending on the study, anywhere from 6.5% up to 60% of people with kleptomania also meet criteria for OCD.
That really suggests some shared underlying mechanism, doesn't it? Maybe
Mhm.
related to repetitive behaviors or impulse control circuits. What does brain imaging show?
Again, we see hints pointing toward that frontal circuitry. Some studies report findings like reduced white matter integrity. Think of it like less robust insulation on the brain's wiring, specifically in the inferior frontal region.
So maybe the stop signal isn't getting through effectively.
That's one interpretation. We also see some evidence, like in one case study, of hyperactivity in the brain's reward center, the ventral striatum, perhaps reflecting an overemphasis on the relief aspect of the theft.
Given how powerful this urge is, how do clinicians track treatment progress and what actually works?
Well, treatment progress is often monitored using specific rating scales, like the Kleptomania Symptom Assessment Scale, or KSAS. In terms of what works, well, SSRIs have shown mixed results, not as consistently positive as in IED.
Okay.
But the most promising finding comes from a controlled trial using naltrexone.
Naltrexone. That's usually used for addiction, right?
Yeah.
Alcohol and opioid use disorders.
Exactly. It's a mu-opioid receptor antagonist, and the results in kleptomania were quite striking.
Now strike.
In that trial, 66% of patients taking naltrexone achieved full remission from kleptomania symptoms, compared to only about 7.7% of those on placebo.
That's a huge difference. Why would blocking opioid receptors help with stealing?
The thinking is that it blocks the reward pathway. If the compulsive stealing is driven partly by the feeling of pleasure or relief, which likely involves the brain's own opioid system, then blocking those receptors makes the act less reinforcing, less satisfying. It dampens the reward cycle.
And I assume therapy plays a big role too.
Absolutely essential. CBT is, again, a mainstay. And given the strong links to OCD, therapists also use approaches like exposure and response prevention, or ERP.
How does ERP work for kleptomania?
It involves helping the patient confront the urge to steal in controlled situations without actually carrying out the theft, learning to tolerate the anxiety until it subsides. Sometimes it's combined with biofeedback to help them manage the physical sensations tied to the urge. We definitely need larger studies, but it's a key part of the toolkit.
Okay, so if we pull back and look at all three, IED, pyromania, kleptomania, the common story really is this overwhelming impulse creating tension, which is only resolved by the act itself, whether it's aggression, fire setting, or stealing.
Exactly. That cycle is the core pathology. And connecting it back to the brain, you see these recurring themes: potential dysfunction in the frontal lobes, the brain's control center, and alterations in the serotonin system, especially clear in IED but hinted at in the others.
Right.
While the research is strongest for IED, the patterns across all three strongly suggest these aren't just failures of willpower, but involve underlying neurobiological circuits. Treatment is still challenging, especially for pyromania and kleptomania due to less research, but that understanding is key.
Which leaves us with a really interesting question for you, the listener, to think about. Considering that strong link between kleptomania and OCD and the consistent brain findings across these ICDs, how might our treatment approaches change in the future if we lean more into viewing these disorders not as character flaws, but as neurobiologically driven cycles? Could we integrate more from addiction and OCD treatments?
It's definitely where the field needs to keep pushing. A fascinating thought.
Thank you for sharing your sources with us and allowing us to take this deep dive today.